So hello to everyone. We are Norwich Pre-Hospital Care Programme. Hopefully you've been to some of our lectures before, but if not, we are a student society based at the University of East Anglia. So this event is going to be covering burns, so the presentation and ways of managing burns, and we are lucky enough to be joined by Dr. Natasha Dole, who is a senior registrar in A&E. So if you could make sure that for the time being your microphones are muted, there will be an opportunity to unmute yourself and ask questions, just to minimise any disruptions. For now, if you can make sure that you're muted. There will be a opportunity to ask questions at the end. If you could just pop them in the chat or message them to me directly, and we'll go through them at the end. The session is being recorded, so you will all be sent a copy of the recording at the end to watch for revision. And another really important thing is that you will be able to get a certificate for this event. You just need to make sure that you fill out the feedback form at the end. So we'll post the feedback form in the chat at the end of the event, and you just need to make sure that you fill it out in order to get your certificate. So that is all from me. I'm now going to hand over to Dr. Dole.
Thank you so much. Hi, everyone. I'm Natasha, and I think let's just get straight to it. I'm going to try my level best to keep this interactive, so bear with me. Okay, so I'm going to be talking about an approach to burns. So let's just kick off. So the main objectives of this talk is to classify burns according to their definition, according to their type, which is basically on their mechanism, the importance of first aid, how to calculate the size of burns, resuscitation, and the Parkland's formula, management of burns, poor prognostic factors, indications to transfer to a burn center, airway injuries, carbon monoxide poisoning, complications, and then lastly, we'll end with a quiz. So here we go. So essentially, there is the main classification, which is basically, it's no longer first degree, second degree, third degree, as it was in my days. So it's now superficial or deep, essentially. And then superficial, as you can see, is similar to these pictures. And your classic example is just sunburning. And it only involves the superficial layer, meaning just the epidermis, very minimal pain, dry and red, as you can see, no blistering. They do blanch with pressure, and normally by day 4, they've healed without any scarring. Partial thickness, as you can see, is something like this. And then that again is divided into superficial partial thickness and deep partial thickness. So this again is superficial, involving the epidermis, but a little bit more than that, meaning it extends into the dermis. And this can often cause formation of blisters that occur within 24 hours. These cause significant scarring, and they can take anywhere between 1 week to 3 weeks to heal. They also blanch with pressure. Most of these burns will weep. They're very painful, and they are also very erythematous. And often they have bacterial contamination, which then causes delayed healing. So partial thickness, you can get deep and full thickness, partial thickness burns. So essentially the full thickness is extended all the way deep down, way beyond the dermis. And sorry, I've just gone too fast there. Often you can get eschar formation here, which then leads to circumferential burns, which are quite a nightmare to treat. And you get lots of denaturing of the skin, whereas with the deep partial thickness ones, they extend deeper into the dermis, and you've got damaged hair follicles and glandular tissue. You can often get joint dysfunction, and these often take more than 2 months to heal. They can change in color from white to red, and they can actually be a combination of both. And they are very painful to pressure. So they're not just painful superficially like the others. And obviously they cause a significant amount of scarring. So this is a classic example of that. You can see there's different colorization and there's blister formation. So these often go on to form eschars, which then need escherotomies. So I think one of the main key take-home messages I'd like you to take home from this is the importance of first aid, which we don't do enough. I think myself included, often if you get a superficial burn at home while cooking, or just, getting into a hot bath, not realizing. So current guidelines actually recommend 20 full minutes of just running water onto the area of burn. And then the three main reasons for that is it reduces edema, it reduces the needs for intravenous fluid resuscitation. And the main thing is it then prevents the need to de-roof blisters that may form. So de-roofing is really important. Does anybody know how to de-roof? Do you want to just talk me through de-roofing? Do you know what I mean when I say de-roof burns? All right, so let me just explain it. So it's essentially, say you've got a big blister here, you give the patient some analgesia, and you can do a mixture of inhalation plus oral. You could potentially use procedural sedation depending on how severe it is. And you literally, with analgesia on top, you take a piece of gauze and you literally just try and burst in a gentle manner, brushing down or whichever way you're going, downwards or upwards, and you de-roof it. The other way is to get out some forceps. So you lift up the part that's blistered and you just snip it, and then you snip all around, and then you're peeling it off. So it can be very painful or not painful depending on the type of burn. And the most important thing is it reduces the edema, which instantly reduces the heat. So you're cooling the area, which then has a significant impact on sepsis prevention. And then you're also improving the actual visibility, because once you've de-roofed a blister, you can actually often see the extent of the burn has increased or is actually not so bad, which then allows for proper assessment of the burn. So in terms of mechanism, so other than superficial and partial, you can also get different types of burns. I didn't want to go into all of them, but we'll talk about some of them. So obviously your main categorization is heat, electricity, friction, chemical, or radiation. And then I'll just leave this on for a couple of seconds just for you to process. So essentially radiation again is things like ionization radiation or chemicals, which then things that will affect your acid-base balance. So your mainstay of treatment with chemical burns is to obviously neutralize the pH as soon as possible, depending on whether if it's an acid burn or an alkali. And this is something you'd use Toxbase for. Electricity, I'll come back to, something that you may see. And then obviously the something that you may also see is thermal burns, obviously then impacting insulation and contact with skin. So in terms of sizing, I'm sure you've all heard of the rule of nines. This figure is something we can easily look up for reference, or it's really easy to remember. Essentially, the front of the head and back of the head are both 4.5% each. And the torso, if you divide it into two halves, each half is 9. So 9 at the top, 9 at the bottom. And the arms together form 9. So 4.5 and 4.5, whereas each leg is 9%, with 1% being the perineum. So that's how you estimate how much percent is burned. So for example, if someone has burnt their whole arm, so that's, and the whole front of their arm, for example, that would just be 4.5%. If someone has burned, say, the front of the arm and the back of the leg and the front of the leg, so front of the arm would be 4.5%, the back of the leg 9%, plus the front, which is 9. So that would be 9 plus 9 plus 4.5, and plus any additional areas that are burnt. So that's where the rule of 9 comes from. The other alternative, which I find often easier, because at the middle of the night, you can't necessarily work out the percent of burns. And in a pandemic, for example, right now, your phone is probably under 1 million layers of PPE. So it's the palm method. So essentially, a pediatric, your whole hand, your entire palm surface is 1%. And your whole hand is 1%, whereas just the palmar surface is 0.5%. So basically imagine you putting your hand all across the burn, and that's how much percent is burnt. So you can use that in peds or adults. And then the slight difference in adults, it's not quite 1%, it's 0.8%. And if you're like me and useless with maths, then it's obviously easier to just go with the rule of nines. So this is extremely important because it helps later on in management. So when I mean it helps with management is once you work out the percentage of burns the patient has, has been burnt, then you can work out their fluid status. So the main thing is obviously burn victims suffer significant dehydration. So you want to hydrate them as quickly as possible. And the ideal formulation used is Hartmann's or Ringer's lactate. So the formula keeps changing, as does most things in life currently. It's between 2 to 4 mils, depending on which guidance you're using and which ATLS principles you're using. What I know at the moment is between 3 to 4 in adults and 2 mils in children, times, so that's what you start with, times the percent that's burnt, times weight in kgs. Just bear in mind, obviously in the UK, most patients know their weight in stone, so you convert that into kilograms. You give the first half over the first 8 hours, and then the second half over the next 16 hours. So that's how you fluid resuscitate them. So obviously the majority of the fluid resus happens in the first 8 hours, which is crucial to their survival. So speaking of pain relief and further management, you have certain burns that will have eschars, which is essentially your black necrotic areas. Those instantly need eschorotomies, and for that you need a significant amount of analgesia. However, patients that require eschorotomies are not normally GCS 15, so you may necessarily, you might be getting away with that, in that you don't need to give them analgesia. But then these are your things in which you could give oral agents if they're GCS 15 and tolerating orally. And then obviously moving on to your procedural sedation, your ketamine, propofol, fentanyl, whatever, ketofol, which could be a mixture of both, your benzos. And then start thinking of, is this a patient a candidate for ICU? Or is this a patient that needs transferred to a burn unit? What is their coagulopathic status? Have I considered feeding issues that they could, potentially arise? Do they need an NG tube? Do they need prophylactic antibiotics? Do I need to give them prophylactic venothrombo-prophylaxis to prevent emboli? And then also little things that we don't think about. What can you do in that instant to prevent long-term scarring or keloid formation? That'll obviously have a psychological aspect. So it's often really good to use photos in this instance to have a baseline, and then plastics often will use that to restore with skin grafting at a later stage. So eschorotomies, and apologies for the gruesome pictures that may be coming up. So it's essentially you're just cutting through to release tension to prevent compartment syndrome. So the main thing is they need repeated serial examinations. And so obviously if you're not qualified, you're not going to do this. But there's very specific delineated areas in which to do it. It's a very gruesome procedure. And most patients, as you can see in this image, they're not GCS 15 and they've had severe burns. So the three main indications to decrease the tension in the burn is basically someone that you're struggling to ventilate. They've got no pulses in the area or significantly decreased pulses, or new neurological deficits, so any focal neurology. This is a patient who has obviously suffered very significant inhalation injuries. And then your indications for someone, or your clinical clues for someone that has suffered this type of injury, would be visible burns that are full thickness, either to the face or neck. They've got a change in their voice. If it's a child, they cry is a different pitch, or it's completely silent, it's completely different morphology altogether. They've got changes in their voice. You'd often see palatal blisters or uvula edema, tongue edema, erythema of the tongue or the uvula. They would be very dyspneic, tachypneic, that you'd often hear stridor, accessory muscle use, harsh bilateral breath sounds, inaudible wheeze, singeing of their nasal hair, or coughing up carbonaceous sputum. These patients are a nightmare to intubate and often will need surgical airways. So when you get a pre-alert, or you're suspecting this, or you're taking this patient, transferring this patient to a center, you need to tell them that they need to get their highest level of staff prepared for this. And often you need ENT and anesthetics for this, including an ICU or an intensivist, especially if it's a pediatric airway. So the main three prognostic factors for these patients is age, more than 60 in terms of their prognosis, partial thickness or full thickness burns more than 40%, and inhalation injuries. This is also something, so those are your classic definitions, but can you guys just think of any further factors that would complicate prognosis? So this is essentially, it would apply to anybody with a poor prognosis with any illness, but any ideas or guesses? No? So
I don't know if you're able to see the chat, but you've got, so someone has suggested immunosuppression.
Absolutely. So give me examples of that. Thanks, Anne. Give me examples of immunosuppression.
So someone said AIDS.
Absolutely. So HIV end stage, so stage 3 and stage 4, meaning full-blown AIDS, your diabetic patients, your patients on chemotherapy or radiotherapy, your patients with leukemias that are, could often present with neutropenic sepsis, extremes of age, so meaning little babies and really old patients, pregnancy, obesity. So those are your main ones for any sort of poor prognostic characteristics in any disease, but more so with burns. So those are your main ones. And then also somebody that's polypharmacy or multiple comorbidities. Obviously, there's increased risk with that. And then any underlying GIT pathology or any underlying hematological disorder that's going to cause further coagulopathic disturbances. So very briefly, electrical burns, the way you differentiate them is low voltage and high voltage, basically being your household appliances, which is less than 1,000 volts, and high voltage being more than 1,000. So the commonest reason for electrical burns is normally lightning. Will be some laborer working outside, on one of those electricity pipes that has then been struck. The three big problems with electrical burns are rhabdomyolysis, arrhythmias, and compartment syndrome. So clinically, can anyone tell me what test or what clinical features you would suspect to see in someone with rhabdomyolysis? And then for a bonus point, is anyone able to describe this image here? It's a very pathognomonic image. And when you see this, it's called something. Any ideas? Can I see the chat? Let me see. It's not letting me see the chat.
There's nothing in the chat at the minute. I will read it out if someone is brave enough. Okay, someone has put discolored brown urine.
Absolutely. So Coke stain urine, absolutely. And anyone with, so Coke stain urine and also no urine output at all, that's a huge red flag. Any specific test that you can do, a blood test that will tell you or that would be suggestive of rhabdomyolysis? Just move this to the right here. UNEs, absolutely. So you'll have deranged UNEs, absolutely, Rachel. So your creatinine kinase, they are often, it's sky high in the thousands, if not 10,000s. So those are your two big clues. And arrhythmias, obviously, with your ECG, and anything specific on your ECG that could hint, say the patient is a normal sinus rhythm, any indicators that this patient is going to go south very quickly. That could be your first initial clue before an arrhythmia. Tented T waves, absolutely. What would that be suggestive of? Hyperkalemia, beautiful. One more thing on your ECG that would be absolutely, thanks Tom, long QTC. So your QTC in a woman more than 460 and in a man more than 480, sort of averaging-ish. So if your QTC is already on the high end of normal, keep that as a flag that this is someone that needs serial ECGs because they have potential risk of developing an arrhythmia. And any ideas of what the sign is called? Absolutely. Well done, Daniel. Lichtenberg figure. So it's essentially fern-like or a diffuse tree. So it's essentially fern-like spidery veins. So that's very indicative of someone that's had an electrical burn. And once you see one, you'll never ever forget one. I think I've seen one once in my life. they look okay. And like you have with your traumatic bleeds, these are your walk, talk, and die patients. So if you see this, be really worried, despite them being GCS 15 with a patent airway. So in terms of when do you transfer it to a burn center, I'm just going to close this or move it this side. So you've got special indications. So full thickness burns, 10% of burns that are partial thickness, or special area burns. So those are your hands, your face, the perineum, genitals, or any joint involvement. Chemical burns all get transferred, inhalation burns, and electrical burns that have more than 600 volts. And then you have special needs, emotional needs, or rehab needs, basically not safe for discharge, or when you are worried about non-accidental injury. So what would make you think of non-accidental injury, just either based on history or clinical examination? Sorry, I meant to switch my mail off. Small immobile child, absolutely. So a child that is currently not crawling or walking that comes in with burns, that should immediately be a red flag. What other indications? Multiple injuries of different ages, absolutely perfect. Well done. The story doesn't fit, so there's no correlation between the history and the clinical examination. Absolutely. Morphology, where, you know, for a hair straightener burn or a burn from a hair dryer, dip burns. Well done, guys. I'm really impressed. Well demarcated. Also burns of different ages, and burns of different stages of healing, and burns of all different areas and sizes. Also, the patient may not necessarily be engaging, or a completely mute patient. And often, because we're in a system with access to previous healthcare records, often these patients have a flag. Safeguarding has previously been raised, or they've already part of a MASH referral, or the child is a looked after child, or has social services involvement, or is on a child protective plan. And don't forget elderly as well. If they're living alone, has it been someone with a long lie, and you know they've had a fall? So think of other morphology as well. Say someone has had a subarach that has then caused them to collapse, and they've hit the heater on the way down and then have sustained a burn in addition. So that's not necessarily non-accidental from a safeguarding point of view, in that it's abuse, but obviously then they're not coping on their own, and you know what their social status and background is. So having said that, moving on to this image, what are you seeing signs and symptoms here of? So essentially they start with headaches, move on to nausea, shortness of breath, collapse. When they recover, they get dizzy, and often they collapse straight again. Absolutely, Tom, well done. So carbon monoxide poisoning, which is a very common complication of burns that we see. And then just remember that this can be in any source. So it can come from the fireplace, a grill, a boiler, a chimney, the clothes dryer, something running in the garage, the car. So again, multiple sources. So just something to keep at the back of your mind. So essentially what happens with carbon monoxide poisoning is all about its affinity for oxygen and how it competes. So basically it competes with oxygen, and the affinity is 200 times more so than what it normally would be. And it's considered to be one of the most hazardous chemical exposures that there is. And carbon monoxide is a byproduct of all fires. So this is an odorless substance, it's colorless, it's tasteless. And again, the patient often looks normal to you, and literally with the click of a hand, they are then displaying signs of systemic features of toxicity. So the mainstay of treatment for these patients is hyperbaric oxygen. And whilst you're transferring them to a center, the mainstay of treatment is high flow oxygen. And again, just bearing in mind the pandemic, if you're seeing this at the moment, this is something you would obviously need to be in full level 2, because this would then be considered an aerosol generating procedure. And the main mechanism behind it is that it reduces it prevents raised intracranial pressure, which could then cause cerebral edema or seizures. So you're rapidly trying to get the excretion of carbon dioxide carbon monoxide out of the system. And also it prevents hypoxia and alveolar collapse in the lungs. So you're trying to reverse hypoxia. It also prevents muscle damage. So it prevents rhabdo from forming. And it also then, one of the long-term effects is it improves outcomes with peripheral neuropathy. So those are your mainstay treatments in terms of how hyperbaric oxygen works. And in terms of complications, if you just go straight body systems down, from heart-wise, you've got your arrhythmias. They get patients, you'll think they're mimicking a STEMI, but it's a complication of carbon monoxide poisoning. You could find focal neurology on them, seizures, psychosis, peripheral neuropathy we've already spoken about. They often present with ATN, which is acute tubular necrosis, and preceding that, they will have rhabdomyolysis, or they will show symptoms of compartment syndrome. So remember your 6 Ps. Do you know what your 6 Ps are of compartment syndrome? I can see the chat. So pulselessness, pain out of proportion, poikilothymia, which I can never pronounce, which is basically changing temperature, then pulse deficit, and pallor. Am I missing one? Did I say 6 already? I think those are your 6 Ps. Paralysis, thanks, Luke. So obviously no movement. In terms of eye signs, they often have retinal hemorrhages, they have visual field defects. In terms of ears, they have tinnitus or hearing loss, and then obviously skin changes, which include redness of the skin and blistering. These patients often go on to develop multi-organ failure, and it's essentially, again, top down. So someone that you are struggling to resuscitate, or someone who you're not able to fix, who's continuing to have hemodynamic compromise, that's when you start thinking, is this person shutting down? Someone that has developed ARDS and you're not winning with them, or you're not able to correct their urine output or their urine deficit, or their serial lactates or CKs or potassium are just going in the wrong direction. Someone whose septic screen is just worsening, and obviously if they are developing DIC, those are your patients that you are then worried about multi-organ failure. So risk factors for massive coagulopathy in these patients, essentially delay in resuscitation. So someone with a long lie or has been difficult to extricate, someone that has been under resuscitated. So for example, they've not deroofed the blisters, or they haven't had escherotomies, and we've miscalculated or underestimated the size, and therefore not given them the correct amount of Parkland's formula in the first 8 hours. Someone who's persistently acidotic, and it's often a metabolic acidosis, and they're often compensated. They often have respiratory failure or respiratory acidosis on top. Someone who then develops hypothermia, massive blood loss that's needed correction, someone whose platelets are on the floor, or someone that's needed activation of major hemorrhage protocol. That was then done as a delayed thing. So that is essentially your whistle-stop tour on burns. Before we do the quiz, do you guys have any questions? Nope, no questions. Alrighty, so let's go through the way the quiz works. So it was essentially to test how well you were listening. So we're going to go through the letters of the alphabet, A to Z, and feel free to unmute to say something. So essentially with each letter of the alphabet, at some point in the quiz, I have given you at least one thing to say with each letter of the alphabet. So let's see how many you guys can get. Obviously there's more than one. Let me just stop for a second and swap. All righty, just bear with me. I'm just trying to get rid of this so I can go slide, and it's not letting me do that. There we go. Let's go slideshow. Okay, so, all right, I'm going to try look at the chat box at the same time. Let me just get that back right. So in terms of A, what could you potentially say to me? What have you learned that's linked with A in terms of the A to Z of burns? Before you go on, let me just read Tom's question. In terms of fluid therapy pre-hospital, how much would you judge requirement for sodium chloride infusion? So if you are clinically happy that it's not somebody in cardiac failure or at high risk of going into overload, I think this is one of the instances you just want to push fluid into them. So you've got 2 large bore lines. I would just go Hartmann's or saline on either side a liter. Like I said, unless they have florid pulmonary edema already that you are worried about, which you could ascertain clinically. Large liver, elevated JVP, livers pushed down, respiratory distress, bibasal crackles, things like that. If they're not showing signs and symptoms of that, they look otherwise fit and healthy, or someone that's GCS 15, pour fluid into them, because I don't think this is going to be a problem for later on. You rather do more in the beginning to prevent long-term harm. Does that answer your question, Tom? Okie dokes. So in terms of A, sure, no problem. Any takers? Arrhythmia, absolutely. So arrhythmia, airway, absolutely. So airway management, extremely important. Signs of airway inhalation injury, extremely important. So that's A. What did I have for A? So basically your assessment, which would include de-roofing burns and making sure you've exposed them head to toe to make sure you can assess every region. And also analgesia, especially for the ones that are GCS 15 or ones with a fluctuating level of consciousness. It's incredibly painful. So whilst resuscitation and fluid restoration is of extreme importance, these patients need proper pain relief. And then just remember, if you're going to be using your procedural drugs, everything has side effects. So make sure if they start dropping their BP, it's not iatrogenic induced, as in you haven't caused their BP to drop, rather than they're actually decompensating and are showing you that something else is going on. So B, breathing. So absolutely. So breathing again, is there labored breathing? Is this somebody that could benefit from an escherotomy because ventilation is a problem? That would be an absolute indication to proceed. Anything else with B? I've lost my, there we go. Bleeding, absolutely. So look out for your coagulopathies. Is this a person who's at high risk for developing DIC? Is this someone that needs major hemorrhage protocol activated? What have I got? So B, your burns referral, your burn center, absolutely, Alison, well done. So blanching is the burn blanching. That'll give you an indication of the classification. So think about your referral indications to a burn center, and then obviously assessing the depth of the burn. C, perfect circulation is my next one. So any others for C? So we spoke about the 6 Ps. You want to make sure there's no there's no compartment syndrome, as well as cardiac complications. Absolutely. Thanks, Claire. So looking out for your common arrhythmias. Often these patients present with arrhythmias that are shockable. So something that's hopefully a quick fix. And absolutely, Luke, carbon monoxide affinity, your features of carbon monoxide poisoning, and your complications of carbon monoxide poisoning. And then also remember, circumferential burns is an indication to transfer. And then those are burns that you should be more worried about. So D, any takers? Absolutely. Well done, Nala. So de-roofing. Other things I could think about was D in terms of disability, meaning what is their GCS? Is it a lower GCS? Is it one that we need to intubate early? Are they showing signs of focal neurology and a disability when you're doing your ATE assessment? Anything else with D? And let's see what else I had. Drowsiness and de-roofing. E, absolutely, Holly. Escherotomy. Anything else under E that you guys can think of? Something I spoke about as a prognostic factor. What would be a poor prognostic factor with E? Elderly, absolutely, Kerry, well done. And one more. So essentially the opposite of that. Well done, Holly. End stage AIDS, and the other E would be extremes of age. So tiny babies, neonates. What else did I have under E? Environmental control is the other thing, just like you have your ATE assessment, making sure they don't develop hypothermia. And just remember, Entonox is great in terms of pain relief, provided they're able to do that with patent airways and there's no contraindications. And obviously your electrical burns, your clinical features, and Lichtenberg sign. So F, fluids, absolutely. So fluid. I can't stress this enough, provided there's no contraindication, for example, in those patients that are fluid overloaded. Anything else with F? First aid, absolutely. That's the one I was looking for. So first aid, running water under 20 minutes. Well done, Holly and Claire. So full thickness burns, assessing the depth, and again, calculating their fluid status. I think that's what I have as well. So G, what do you guys have to say for that? Any takers? I actually can't remember what I had for G. Absolutely. GCS is one of them. Well done, Colin. So low GCS or, repeated OBS to monitor for GCS changes are just remembered. So sugars, so glucose, G was for glucose. They often become hypo or hyper very quickly. So to keep track of that and correct. And GIT failure. So to remember, is this someone that is at high risk of developing GIT failure? Do they have deranged LFTs? Is this someone that needs a NG tube as soon as possible? Those patients often that need NG tubes are ones that are intubated. So essentially you guys would intubate them pre-hospitally, bring them to us. We double check the intubation is still fine with no complications, and then pop an NG tube in as soon as possible. H. Hartman's, absolutely, Holly. The first thing I just thought of now was hypovolemia, absolutely. So history taking, signs of NAI, hyperkalemia, well done, Tom. Your ECG signs, your classic tall tented peak waves. If they become hypokalemic, your U waves would be an indication for that. Serial blood gases. Anything else with H? All right, hyperbaric oxygen for carbon monoxide poisoning, and hoarseness, absolutely, high and low voltage. Nice, Alan, I didn't even think of that. In terms of your electrical burns, meaning more than 1,000 and less than 1,000 volts. So intubation, absolutely, your indications for intubation, intravenous fluids, that's right, Tomasz. I don't know if your IV was intravenous or investigations, either or. So the importance of intravenous cannulation, 2 large bore lines, and investigations, early blood sampling. Well done, Nala. Inhalation injury, your features of inhalation injury. And then the other eye I can think of now is imaging. You want imaging as soon as possible, and basically starting with bedside things. You could do a bedside fast, look at their aorta, see how underfilled they are, and also just a chest x-ray to see, fluid overload, if you're in the right place with your ET tube after you've checked your capnography, etc. So where are we at? And we've spoken about this. And again, remember your indications for both escherotomy and transfer to a burn center. So J. So this one, I had to think outside the box. I did mention the word, but I don't think I mentioned it. So let me give you a clue. It's something to look for on your ECG, which we didn't speak about, I don't think. It's a bit sneaky. J point, yeah, that could be. What is the J point normally indicative of, Luke? Or anyone else, doesn't just have to be Luke. So your J point is normally where you're measuring to look for ST elevation, not quite what I was looking for. So this patient is going to be very unlucky if they're then developing ACS, which is a complication if they've had severe burns. So essentially hypothermia, what do you see on your ECG? So it's called Osborne waves. Absolutely, well done, Greg. So the other word for Osborne waves is J waves, which could also be an early indication that their temperature is dropping. So you can often see this on a rhythm strip in the intubated patient, because I mean, you wouldn't necessarily know instantly their temp has dropped. So for patients like these, they often get rectal temperature monitoring because the tympanic is obviously not accurate. The one I had gone for initially was joint involvement because that would be a indication to refer. That counts as a special area burn. So indication to refer to burn center, early photos, and early plastic involvement. So K, where are we at for K? So I think I cheated and I went for kalemia because I couldn't think of another K. So do you guys have any ideas for K? Ketamine, well done, Tomasz, nice one. So ketamine works beautifully. It's pain relief. It's for sedation. It's got good properties. You can use it even in patients with raised intracranial pressure, limited side effects. So it works beautifully. Anything else with K that you guys can think of? Kidney failure, absolutely. So signs and symptoms to look out for. Is this a person who's very quickly developing or has developed kidney failure? And then the other K I can think of now is kinase. So your creatinine kinase, again, rhabdomyolysis. When I made the presentation, what I jumped to was keloid formation, because again, remember, especially if it's a special area that's been burnt, those, for example, the joint, they have very high risk of keloid formation and obviously burns that extend into the dermis. L, what do you guys have to say for L? Absolutely, well done, Nala. Lichtenberg, I think that was the only L I had as well, and liver failure. So watch out for signs and symptoms of liver failure. M, what do you guys have to say for M? MSK, signs and symptoms, well done, Claire. So look for any MSK features that they could potentially have that you want to try and prevent. Massive blood loss to indicate, absolutely, to indicate this is a poor prognostic sign. And again, you need to activate major hemorrhage protocol. I don't think I had a mechanism of injury. Again, you want to make sure it's not NAI. And again, are they developing multi-organ failure? N for NAI, absolutely, Rachel. So I can't stress this enough with burns, especially in something that's unexpected and the history just sounds wrong. Absolutely, Claire. Nutrition, super important. It's part of your critical care for your intubated patients. And then early insertion of NG tubes. Anything else with N? What did I have? So nasal hair that's singed, neuroprotective measures is the one I had gone for. So little things like elevating the bed, giving them seizure prophylaxis, VTE prophylaxis, considering treatment to prevent raised intracranial pressure. Any drugs that come to mind when I say that? Two specific, or actually 3 drugs that I can think of. Any guesses? Or let's say they have, absolutely, well done, Rachel. So mannitol, hypertonic saline, and one more that's also used with COVID. It's a steroid, dexamethasone, absolutely. So those 3 that often get started either in prophylactic doses or treatment doses. O for organ failure. I've just thought of what I forgot to say under I, or mention in my talk, is intraosseous. Often these patients, you guys would know, they're not easy access. So when you bring them to us, they often, your first point of care resus is through an IO line. Absolutely, Sophie. Edema, oxygen, hyperbaric oxygen or high flow. And then remember regular OBS, remember eye involvement, your retinal hemorrhages, and again, poor prognostication in your morbidly obese patients. P, Parkland's formula, absolutely. Super important. And again, just remembering it can range from 2 mils to 4 mils, depending on what you're using. Well done, Alan. Your 6 Ps, pain, position. The other thing I can think of is pulselessness, and again, evidence of compartment syndrome, where we've said that already, and paralysis. The palm method, early plastics involvement, psychological aspects, looking for pressure sores or preventing pressure sores. And then is there evidence of poisoning? Was this a self-harm? Was this someone who's tried to commit suicide and, you know, locked themselves in the car and driven off somewhere, left the engine running? And then obviously your palm method, depending on peds or adult, and 0.5, 1% or 0.8. Q, absolutely. Your QTC interval, I think that was the only one I had for Q. Oh, I didn't even have that. So well done, Nala. R, what do you guys have to say for R? Rhabdomyolysis, rule of 9, ringers, absolutely well done, guys. I think I had pretty much the same. And then also raise intracranial pressure and respiratory signs, referrals, absolutely, indications to refer on. S, your saturation, well done, Colin. Size, absolutely, Hannah and Claire. Safety, well done, Soph. Need for safeguarding, absolutely. That was the one I was thinking of, Alan. Safeguarding, severity, and I think the other sign, the other S was signs and symptoms, and absolutely sepsis. So what I didn't speak about is your sepsis 6 bundle. So Patricia, do you want to give it a try since you've mentioned sepsis, or anyone else? What is your sepsis 6 bundle? Have you guys heard of take 3 and give 3? So absolutely, early antibiotics. We've got 5 more to go. Give it a try. Oxygen, absolutely. 4 more to go. Fluids, beautiful. Take blood cultures. And we're missing absolutely 2 more. So lactate and urine. So what is your aim for urine output in these patients? So in a child, it's 0.5 milligrams per kg per hour. And in an adult, it's 1 milligram per kg per hour that you're aiming for. So yeah, we've gone through all of this. And then again, signs of shock. Rachel, no problem. Off topic, can you get surgical emphysema as a sign in partial full thickness category? You can, absolutely, but that's then probably telling you that they have developed something like a pneumomediastinum. So you need early help there. Those patients will then need theatre. So yes, you can. T, where are we at for T? Types of burn, well done, Colin. Thermal, absolutely. The other T I can think of is temperature, and absolutely trauma and associated injuries and timely treatment. I cannot stress this enough. And well done, Claire. Thromboprophylaxis. So starting them on apixaban or dalteparin. And I think we spoke about this already, the thickness, assessing the size. Oh, I didn't even get there with T, apologies. U. Again, I think I mentioned this in this talk already. What can you guys say for you? Any takers? Urine output, well done. Uvula, urine, one more on the ECG. So what do you see with hypokalemia? Absolutely, well done, Tom. So your U waves or your T waves in hypo and your U's and E's, well done. And the patients, remember again, the ones that are unable to ambulate, they're going to need, regular fit assessments. You want to prevent pressure sores, and then just make sure they're not under resuscitated and they don't have edematous uvulas. Okie dokie. So for V, what do you guys have? Venous access, well done. The one I can think of at the moment is volume assessment. Are they underfilled? Any other takers for V? Voltage, absolutely. So visibility, high and low voltage. Are they vomiting? Are they at high risk of aspiration? And again, your visual fields, and absolutely, Nala, your VTE, so to prevent your emboli. W, I'm not sure I had a W. Any takers? Water irrigation, well done. Water, well done, guys. Much better than I am. Any other guesses? Weight, absolutely. That's a really good one that I should have thought of. Absolutely. So everything is weight-based to work out further drug dosages and treatment. And in terms of X, which I've gone too far, was essentially X-rays to make sure that there are no underlying injuries. And again, for example, in a child or a patient that you're suspecting NAI in, to make sure there's no underlying fractures on top of the burns. Anything else that you guys can think of with X? And then Y. I'm not sure I had a Y. Any takers? Yeah. Oh, I did. I had the yelling patient and the young patient. So again, just beware of extreme of age. So initially, Karen, when calculating Parklands, it's based on the ideal weight. Sorry, it's based on the estimated weight. And then later on, once you can weigh them, it's on their actual weight. Anything else with Y? All right, Z. I'm not sure I had a Z. Any weird and wonderful takers, ideas for Z? Yep, I did not have a Z. If you guys can think of a Z, let me know. But I think that's me and done. So that was essentially a whistle-stop tour on the important things to look out for in terms of burns and how to treat them, what to look for, what to do. And yeah, I hope that was helpful. Do you guys have any more questions?
So thank you, Dr. Dole. That was a very interesting talk, and I think the most interaction we've had in one of our talks. So if anyone has any questions, please put them in the chat. I've also posted the link for the feedback form, so please make sure that you fill that out if you want to get your certificate, and it will also be really helpful, of course, for Dr. Dole.
Please do. Absolutely. So if we use, I think in South Africa, definitely, since I'm pre-hospital back there, we use cling film very much. And we use Burn Shield, and here they use Burn Shield or the equivalent thereof, or even silver nitrate and Mepital. And then cling film is often what we use to transfer to a burn center, especially here where I work. So it works beautifully, and it also cools the skin, and it also apparently prevents scar and keloid formation. Any other questions? Absolutely. HEMS for severe burns, very much so. I transferred severe burns via HEMS back home in South Africa, and it's one of the indications to activate HEMS. There obviously you need extensive experience with that because their airways are already buggered to start with if they've got a difficult airway. or they've got airway burns, and then it's even higher risk. And obviously these patients, if they've got chest issues, then they could potentially end up with pneumothoraces. So you need to obviously weigh out the pros and cons and how far you are from the referral center. Any further tips for paramedics pre-hospitally in terms of burns? I can't think of any, other than I think if I was a patient with burns being transported and I was GCS 15, I think pain relief, which you guys are really good at anyway. Be mindful of morphine because it can obviously drop your blood pressure and cause rest suppression. It's great if you're going to give it in increments and as an initial thing, but this isn't a patient I would keep topping up after you've given 10 of morphine with more morphine. I would use something like ketamine or benzos. Let me just go back. Obviously, immediate cooling with running water, but golden window to provide this. So the golden window, Alison, is the first 20 minutes or for 20 minutes as soon as you can do that. Obviously, I think if you're a couple of hours in, you've missed the boat there already. Use of antibiotic prevention, absolutely. So I appreciate it's now becoming a PGP for paramedics in terms of prophylactic antibiotic cover. Obviously, if they're pen allergic, you're not going to give them penicillin, but penicillin would be the go-to. Otherwise, just a broad spectrum. So ceftriaxone, because there's only a 10% cross-reactivity. So depending on PGP and what you guys are allowed to give, I think if you can give stat antibiotics pre-hospitally, then we're just absolutely hitting the nail on the head. What did I miss? Use of antibiotic, any minimum percent of, so in terms of when to give antibiotics, there isn't a minimum percent. Any indication of sepsis or any patient high risk of sepsis or high risk of poor prognostic factors, you would just throw in those antibiotics. And again, I think one stat dose is much more beneficial than nothing, and you're doing more benefit to the harm to the patient. Tom, should patients presenting with burns post 72 hours still be dressed? No, so not post 72 hours. You want to change them to, mostly we change them either to ongoing Mepitil or Gelinet or silver nitrate dressings, depending on their size of burns and what we're doing for them, and whether they're going in to have escherotomies or not, and again, whether they're going into theatre for a full debridement or not. So there's a few things that will depend on whether you continue with cling film, but definitely not cling film after 72 hours. Hannah, in your trust, they've taken away intubation to road staff other than selective teams. Oh, I'm sorry to hear that. Any tips for airway or just rapid transport? So this is a difficult one. It's kind of like your polytrauma patient and you think, should I do as much as I can on scene or should I scoop and run? So I think it depends on the scene and it's going to be a case-to-case or individual-based technique. I think if you're worried about airway and you're a long way away from the referral center or your definitive hospital, you want to fix airway as much as you can. If it's simple things, jaw thrust, chin lift, put in an OPA or an NPA if you can, and then get to a nearest hospital to stabilize and then onward to definitive center. Whereas if you've got no airway to fix and it's all just burnt, are you skilled enough to go ahead with the surgical crike? And depending whether you've got experience in that or not, go ahead with that. But if you're not, then I think your nearest hospital to stabilize and then onward to definitive care. Tom, Comox is normally the go-to, so 1.2 as a stat dose. Patient in cardiac arrest with major burns, would you still work or look at injuries incompatible with life? Not following your question. A patient in cardiac arrest with major burns, would you still work or look at injuries compatible with life? Sorry, yes, because with a major burns patient with cardiac arrest, you've got a lot of H's and T's that are corrected, and essentially you're going to keep going until you've fixed all your reversible causes. And again, it's a judgment call, but initially I would probably do prolonged resuscitation on these patients because their gas, I guarantee you, will have things that can be corrected. the problem with this patient is it's not going to be the burn that kills them. It's going to be a complication of the burns that kills them, if that makes sense, Chris. I hope that answers your question. Alison, cooling burns with children always causes issue with anxiety and stress for a patient. Any suggestions? Entonox is your friend. It makes them high. It makes the parents very confident that you know what you're doing. And then you just go ahead with them. And I think with parents, with pediatrics, your key issues that you have are high maintenance parents, at least in my experience. And if you can win the mom or dad over, they will then enable the child. Whereas if you've not won the mom or dad over, then you're essentially just playing with fire, no pun intended. So I think that's the way to go with them. Bribery works like a bomb, and child-friendly environment, like having a play therapist, putting on, I can't think of a song at the moment, Baby Shark, or, a Barney song that they could sing along to, distractions, having some soft toys, and like I'm saying, bribery, simple things like, mommy will get you ice cream if you do this, or you can get an extra hour of TV, speak to the parents beforehand, work it out logistically and get them in your corner. Luke, Luke, you're saying, do I think absolutely. So we do de-roofing pre-hospitally in South Africa. If you Google how to de-roof, I think anyone can do it. I've taught my very non-medical brother how to de-roof telephonically. He's currently in Washington in DC. He'd had a nasty burn, and I literally over FaceTime talked him through de-roofing his burn, which saved him a trip to the ED. So it's literally a very simple procedure. If you just Google the video or Google it on YouTube, otherwise just text me, I'll give you or send me an email, I'll send you the link. It's really simple to do, because then that way you guys can also assess how bad it is. For example, if it's really bad, then you guys can divert straight to a burn center if the patient is stable, rather than coming to a hospital that's not a burn center because you've not adequately assessed because of the blisters, if that makes sense. Karen, what is a rough guide of water temperature? So it's basically lukewarm tap water, not ice cold, because that's going to hurt like hell. Talking from personal experience. And the golden window, 20 minutes within the first 3 hours. I'm not sure about the first 3 hours. I'd have to check data on that. I thought it was the first 2, but to my knowledge, more than 4 is a bit late. But it's definitely within the first 20 minutes for 20 minutes. Here to get you that video. Hopefully I've answered all your questions and not missed any. If I've missed anything, just re-type it.
I'm just going to send the feedback link again, because I think it might have been buried in the chat. So that's just there if anyone needs to fill that in. But I think we'll hang around for a little while longer in case anyone has any other questions. Just feel free to put them in the chat. Otherwise, if there are no other questions, thank you very much for delivering this talk. It's been really interesting and really interactive. So thank you. And thank you to everyone for coming. I hope you enjoyed it.
Thanks so much, guys. Thanks for all the feedback. Please stay safe. Yeah, and like I said, you've just pinged you my email address at the top. So just ping me a message if you have anything more to ask. Otherwise, thanks very much.